So thank you, everyone. It's really nice to see all of you this afternoon and for joining us for the AIM RSF Open Invitation Seminar for October 2022. A few words about the RSF in case it's the first time you're joining these meetings. So many people are living with multiple long-term health conditions, yet actually we don't know very much about how those conditions develop. So the National Institute of Health and Care Research directed £23 million towards research to identify and help treat multiple long-term conditions. That is the AIM program, which stands for AI for multiple long-term conditions. And the idea is that those research programs will help establish research to better understand and treat multiple long-term conditions. Hosted by the Alan Turing Institute in collaboration with the Swansea University and the University of Edinburgh is us, the dedicated research support facility, often abbreviated to RSF, which has been established to facilitate research collaborations and to offer AI and advanced data science expertise to the teams that work across the various AIM research consortia or research collaborations. The overarching ambition of the research support facility of the AI for multiple long-term conditions project is to support and advocate for open, inclusive, and collaborative practice that delivers research that is greater than the sum of its parts. If you'd like to learn more about us and get involved in our research, you can do so by visiting our website, which is at the Turing website under Research and Research Projects, and then a very long name that is AI Multiple Long-Term Conditions Research Support Facility. A bit of housekeeping before we get started. As you can already tell, the talk will be recorded, but we will not record the discussion. And we will also not be recording the chat afterwards. So please use it in any way that you want. You can use it to post your questions there, and we will make sure to try and answer those at the end of the session. You can also ask questions at the end of the session by raising your hand. If you see any issues, you can report them to me, Irini, or to Dave Chapman, or to Sophia Batchelor, who's a community manager in the program as well. As all events by the Turing, we follow the Turing Events Code of Conduct, which you can find in the link here. And that is what I was thinking about when I said use the chat function in however way you want, that abides by our code of conduct, please. And if you would like to engage with our research programs, you can do so through our program webpage, which was linked in the previous slide. We have monthly seminars like this one. We also have kind of knowledge shares between the consortia where we talk about research or topics that are of interest to the research collaborations that make up the AIM program. And you can also communicate with us via our Slack or our email. Just a heads up that our next RSF seminar is going to be again on a Tuesday on the 8th of November at the same time, 1:30 to 2:30. And with that, I would like to hand over to our speaker, Krish Kumar, who is a professor in health data science and public health at the University of Birmingham. And Krish will talk to us about Dexter, which is a semi-automated system for efficient, transparent, and reproducible research. So over to you, Krish.
Excellent. So I'm Krishna Narendra Kumar. As you can recognize, it's a lot longer than the AI Research Support Facility name. And so, as introduced, I'm a professor of health data science and public health at University of Birmingham. I'm also trained as a public health medicine consultant and hold honorary appointments with the University Hospital Birmingham. No more Public Health England, but Health Security Agency. I'm also a Turing Fellow at the Alan Turing Institute. These are my various things I'm engaged with, which I need to disclose. So I'll just briefly give you 10 seconds or 15 seconds to have a look. Various funding bodies. I also am what do you call a trustee in a charity, and also work as a director in the Open Clinical Social Enterprise, both not remunerated. Okay, so today's presentation I will take through, given there are early career researchers as well. So some of the very basics around electronic health record database research, the challenges for open, transparent, reproducible research. I will introduce you to Dexter and how we are extending the Dexter capabilities beyond observational research, for example, in clinical trials. Our plan in the future on how best we can encourage open electronic health record research and analytics, and what we hope to do in the future. So in University of Birmingham, we work with a range of electronic health records, primarily primary care database, such as CPRD Gold, ORM, and THIN database. You will note these come from different electronic health record system. For example, CPRD Gold and THIN comes from the Vision electronic health record, whereas CPRD ORM primarily comes from EMIS electronic health record used in primary care. We also work with secondary care databases like the Pioneer Data Hub, but also with Insight Data Hub. Lately, we have been working on maternity care data, and I will come to that later on. So if you take a typical electronic health record database, this is THIN database, one of the smallest, but has got 18 million patient records. This means over 4 to 6 billion data points, and using that for research can be hugely challenging. So in a primary care database like this, you will have patient records where the demography will be described, therapy records where every prescription will be described and documented, medical records where symptoms, signs, and diagnosis particularly are recorded, and what we call AHD records, where you will get physiological measurements like blood pressure, BMI, but also blood results like laboratory results for hemoglobin A1C, and serum creatinine. You get additional information, for example, the deprivation level, etc., from these electronic health records. So what are the key challenges when you are using this electronic health record? The main thing is they are essentially collected for clinical and administrative purpose. This means when you use it for research, there is a whole range of biases that you need to take into account. And what this means is, if I were to do a piece of research 8 years ago, I will essentially plan a study, write a protocol, get approval, and then I go to a person who can extract the data according to the study design that is specified. And when you design an epidemiological study in electronic health record, there are numerous biases. For example, immortality, time bias. And it is important you design your study so that you do ensure these biases are minimized as much as possible. So if I go to a person, I could take as many as 3 to 6 months before I get a data set. If I give the same specification to 10 different people, I'm sure you all will recognize that all of them will give me 10 different data sets, even though the source data is the same. And there's no way we can verify this. So it takes a lot of time, and we really don't know if it is reproducible, even the data set itself. And despite all these challenges, I'm a great believer in the wealth of data that comes from electronic health record. I often compare this to fractional distillation. It's like crude oil. Crude oil, which is obviously very impure, but if you do the right thing, you can then separate them into very highly purified, for example, LP gas, to less purified, something like fuel oil or bitumen. One of the key things is all of them, irrespective of how impure they were, they are all very useful at different levels. And I always believe it's the same with routinely collected data. As far as you use it, understanding its limitation, interpret the information cautiously, it has huge volume of information, and that can be used to generate knowledge. As you know, I'm not just an academic, but also a public health physician, and this is what I believe in. So whatever knowledge you generate from electronic health record research may be insufficient to satisfy the intellect, but still, for me, as a public health practitioner, it provides me with sufficient information to make decisions. And that's very, very important for a person like me. So to essentially, to tackle this challenge, we innovated Dexter. And what does Dexter do? As I mentioned earlier, the typical study cycle in a real world evidence, you come up with a question, do the review of the literature, you define your variables, get the study design, get the approval, you get stuck when it comes to then accessing the data in an analysis ready format. And this is exactly what we did with Dexter. Essentially, we knowledge engineered different epidemiological study designs. So it's not about extracting and creating a cohort, but beyond that, being able to design a good quality epidemiological study. For example, in pharmacoepidemiology, you might use new user design, or prevalent new user design, or time-dependent design. So even within matched cohort study, there are a huge number of designs that we encounter on a day-to-day basis. So that's the primary aim of Dexter. And this took us 5 to 6 years, and we continue to develop for various different scenarios and different designs. On top of that, lately, we have been working on automated analytics, so you can get results as well. We'll come to it, why we would need those results. So essentially what we did was we looked at different study designs, mapped them, and put it into, as you all know, many of you are computer scientists, into an ETL format, extract, transform, load format. And this meant we were able to all of a sudden do studies much more quickly. So Krishna, left of my screen, is the innovator and the computer scientist who created it. And on the right, you have people with expertise in ontologies, natural language processing, even though we are not using NLP at the moment. George Singh Chandan, another public health physician and epidemiologist, Konstantinos, a clinician, and then we got Professor Peter Tino, another computer science expert. So you can see, one, to create something like this, you need a very multidisciplinary team. The second thing is you need to be co-located, not on Zoom. So Krishna and myself essentially sat for hours, days, nights, weekends in the first 2 years together, so that we both understand each other's language. Let it be his language in computer science as opposed to my language in terms of epidemiology and clinical medicine. This meant all of a sudden we could access database better. In 2014, we would publish 3 papers for a year after paying £50,000 for the data. Now we can do 30, 50, whatever you like. But more importantly, I will show you the growth of the team. So we found this very useful. All of a sudden, you can extract data, which took 6 months, in 6 hours, or even 60 minutes at times. All of a sudden, you can access it 24 hours. And there was this gap that was being closed. And you get the same data every time you extract, unless, of course, you want a different set of controls. Building on that, during my time with Health Data Research UK, I went on to learn more about pharmacoepidemiological studies, and we started building designs specific for example, pharmacoepidemiology studies. And recently, with a large multi-morbidity grant to look into health of people with multiple long-term conditions in pregnancy, the consortium known as MumPredict, we will develop an automated infant mother-linked studies platform as well. So what does a study typically look like in electronic health record? Here is a very basic, simple matched cohort study. So women with polycystic ovarian syndrome are the exposure, women without polycystic ovarian syndrome are the control arm, both matched for age and other parameters we use specify. One of the key things, what some of our colleagues were worried about is their high risk of getting a condition called non-alcoholic fatty liver disease. So we looked at the association between polycystic ovarian syndrome and non-alcoholic fatty liver disease. And what we found was they were twice more likely to have non-alcoholic fatty liver disease. Now, that's not terribly new. So what is it so important about it? The second thing we showed was that this was independent of if they were obese or not. So it was not just obesity that was driving the process of them having non-alcoholic fatty liver disease. The second bit was even more interesting because these are large databases. We had testosterone values for over 70,000 women. So one of the key features in polycystic ovarian syndrome is they have what we call androgen excess. They have more testosterone than you would expect in an average woman. So we were able to show the greater their testosterone was, the greater the likely chance they had non-alcoholic fatty liver disease. This was very important. And then based on this data and additional laboratory work, my colleague, Professor Wib Kealt, then got a $3 million grant to actually develop drugs that are anti-androgen properties, tackling specific receptors. So a simple study that can lead to new ideas, new innovations, new findings, and development of new drugs. A recent study published in Nature Medicine, a simple matched cohort study looking at 115 symptoms for long COVID, and we did it in CPR-Diorum, and you can see a range of symptoms that were present after 3 months in people affected with COVID. Here is another study where we looked at people with hypothyroidism, so people whose thyroid functions are low. So one of the things when their thyroid functions are low, we replace them with thyroxine treatment. And when you replace with thyroxine treatment, the response is measured by looking at their hormone levels, a hormone called TSH. So the usual range a person tries to keep this hormone is between 0.5 and 4. But there were no evidence if we should keep it close to 2.5 or 3.5 or 4, we didn't have evidence. And we will never, ever have a randomized controlled trial evidence to do this sort of study, because it will take a long time. No one is going to fund a study for a very, very cheap medication, and it takes a very long time to look at these outcomes. So we looked using observational data, and what you see here is in that normal range, mortality did not differ. But if it was low, or if the TSH levels were high, then the mortality was high. And we looked at this also in cardiovascular disease, etc. So a simple study that can inform clinical practice. This is another study looking at policy. So previously, when women went into childbirth, what we do when they have a cesarean section, we usually clamp the cord once the baby is born, and then only give an antibiotic to the mother to prevent infection in the mother, wound infection. But what they found using a trial was that if you give the antibiotic earlier, before the surgery, before the cesarean section, the wound infection and maternal sepsis was lower. So this came into practice in the NICE guideline. But people were worried, because if you give the antibiotic before you clamp the cord, then the antibiotic will reach the baby. And they were worried that antibiotic in the baby's tummy will alter what we call the microbiome, and this will lead to future risk of asthma and other allergic disorders. So this is a very difficult study to do. We've used what we call a controlled interrupted time series, a modified version, I would say, of controlled interrupted time series, looking at asthma and other allergic diseases before and after the policy change. And we didn't find any increased risk, which was very important, equally important to show. So from being just me in my team and then Krishna joining as a student, we now have grown into a team of 25 to 30. And the only reason I'm saying this is, with Dexter at your hand, the possibilities for growth as a team, the amount of science we can do can be huge. And I'll give you some more examples. So we were able to empower the clinicians. So there are 5 clinical groups, the gastroenterology group, for example, the ophthalmology group, who independently are able to now work, don't need our support, and conduct their own research. At the same time, bringing in lots of research funding to the university as a whole. So I'm going to show you what was started for observational research, how it has progressed further to do other types of research, and how we are using Dexter. Okay. So the first one, I told you, we lead a consortium in multiple long-term condition called MumPredict. This is not the AIM-funded one, but this is the MRC strategic funding, which is a 3 million project across the 4 devolved nations. This is to research to improve care for pregnant women living with 2 or more health conditions. As you can see, there is a number of universities involved. More importantly, they come across all 4 nations, and they all have one focus, and that is to improve the care for women who go into pregnancy with 2 or more long-term health conditions. And the beauty is the consortium is like a family. They all work together equally well across boundaries, share good practice, and driven by primarily the early career researchers. And we are very democratic in the sense we all lead our own pieces of work, but at the same time ensure leadership is carried forward by another person. For example, the MumPredict 2.0 will be led by my colleague in Scotland. MumPredict Global will be led by my colleague in Wales. We use a whole range of databases for this project, and we are hoping some of the databases will implement Dexter to make research more easier to do. The second element, moving from retrospective study, I want to talk to you about a prospective cohort study. So, and importance of getting representative samples in your studies. So this is a long COVID study. I earlier showed you a slide where we did a retrospective study looking at symptoms in long COVID that has been recorded in primary care. But as you know, only 20% of symptoms are probably recorded in primary care. Others are available as free text. But again, this will only capture those that go on to have some sort of contact with primary care. So if we were to overcome this, and if we want to study more, we need to prospectively recruit people who have been affected by COVID. So what we are doing at the moment, led by my colleagues, Shamil and Melanie Calvert, we are recruiting people with COVID through the electronic health records, working with CPRD. So to get a representative sample, we use Dexter to find them in a similar age and sex distribution, but oversampling ethnic minority population and so on. It has been difficult in terms of recruiting, and that is a new challenge we are encountering. But that's one example of doing prospective cohort studies, where we will also collect blood samples, where we will put wearables to monitor them much longer. Third example I'm going to give you are clinical trials. So this is a trial called Dare to Think, led by one of my colleagues, Professor Deepak Kotecha and Dr. David Shukla. So in this study, what they are looking at is atrial fibrillation patients who were previously classified as intermediate or low risk and were not offered what we call anticoagulants, that is, medications that thin the blood to prevent stroke and other cardiovascular events. So what the new thinking is, with new drugs that are much more safer, these people also should be given anticoagulants to prevent stroke and other cardiovascular events. So that's the study. Okay, so intervention is what we call anticoagulants. And the population is AF, low risk. Comparator is no therapy, which is what we do at the moment. And the outcomes are these. Okay. But before you do the study, you need to plan your study well, not trail, but trial. Planning is important. The first thing is you need to establish there is a need for a trial. So you need to show that low risk population with atrial fibrillation are at increased risk of stroke. And you can do it with Dexter by doing a matched cohort study. Secondly, if you are recruiting people over 3 years for a 5-year trial, so 3 years recruitment and outcome studied up till 5 years, you need to know how many people will be eligible and would you have enough people to recruit. Thirdly, you need to look at the validity of the outcome you're looking at if it's a data-driven trial. So can you capture stroke, heart attack, etc. through data rather than having to go and ask the patients at the end of the trial? 4, you need to know the outcome incident rate so that you can do your power calculation better. 5, you need to plan if you can do safety monitoring using this. For example, bleeding is an event we are worried about when you give this anticoagulant to thin blood. So you need to be able to look at that. Finally, because it's a medication that already exists and are prescribed in the community and quite often prescribed to people who should not be getting, the low risk people, you have the opportunity to emulate the trial, essentially use the data to emulate the trial and see what sort of effect it will give. If it shows it's not going to give an effect or it's not going to work, then it's probably not a good idea to go with the trial, millions of pounds. But what we found was it will reduce stroke by 30%, and that's what we hope to see when the trial finishes. This has started now, and that's what's ongoing. How about conducting trials? So we have a trial funded called Radiant, led by Dr. Francesca Crow, my colleague. And in this, we are working with industry to run a trial. The trial is very simple. There are women who have gestational diabetes during pregnancy. We know the gestational diabetes then resolves after pregnancy, but they are at increased risk of diabetes in the future. Now, one of the key things is, in the guideline, we say that we should look for diabetes yearly, screen them for diabetes yearly, but unfortunately, only 30% of women come for yearly screening. So we want to have an intervention that encourages women to come and screen for diabetes. So the intervention is very low cost, just an SMS, along with animation explaining why it is important to screen for diabetes, and we will randomize women to either receive the intervention and not receive the intervention. And then we will look if that has improved screening rates. So this is sort of the diagram. The whole thing is going to be data-driven and digitally driven. So we will, within the university, find the eligible population, pass it on to SEDIM, who are the Vision Electronic Health Record colleagues. They have something called an outcome manager, within which they will also help with defining the population and also randomizing. Once they have randomized them, then it will go into the electronic health record. Data will collect when they have come for screening. The data comes back to us, and we will use Dexter to analyze and then produce the results. So the whole process being digitally driven. I won't go into that detail. The last two things I want to touch on is about learning health system, and then of course the Optimum, which is the AIM project, as in artificial intelligence in multimodality project. So another user case scenario is how we are going to use Dexter for learning health system. So this is a very small project we did for called Learning Health System for National Health Service, LHS for NHS. And those who know the pillars of learning health system, we say three things: knowledge, practice, data. How do you get knowledge, existing knowledge, into practice? How do you capture existing practice into data? And then thirdly, how do you use data that you have collected to generate new knowledge that could be then put back into practice? So what we do with Dexter is data to knowledge, generate new knowledge from data that has been created. The other arm is knowledge to practice. This is typically a decision support system where you put your existing knowledge into practice. We are using the Open Clinical platform to do that, and I'll come to that. The third element is practice to data. This is good quality electronic health record and good quality data. So knowledge to practice, practice to data, data to knowledge. I will demonstrate this giving a short example here. So this is the cycle I'm talking about. So knowledge to practice, we are going to use openclinical.net to create computer executable guideline. Practice to data, we are going to use the electronic health record called PICS in our local hospital, and the data captured from him, which is stored as Pioneer. And then from data to knowledge, we are going to use Dexter to create new knowledge. How do we do it? My colleagues who were involved, Alvina from UCL, who leads some of the work in Informatics Consult and this particular project, and my clinical and other colleagues are present here. So take this as an example. Benjamin is a 68-year-old man, comes down with COVID to the hospital. He has a history of diabetes, and he also has a history of excess alcohol intake. Let's talk about capturing data. Benjamin obviously has excess alcohol intake, but if you look at electronic health record, how to record alcohol intake, that itself can be quite varied, and people record it in various ways. So my colleagues, Niraj Bala and Shamil Haroon, develop standards in our team that can be used to collect information around alcohol intake. Very simple project, nothing to do with Dexter, but extremely important. Very basic thing, but extremely important, probably the most important thing. And this meant in our local hospital, now we collect data on alcohol well. This means a lot of important things. For example, if someone has got excess alcohol problems, we can refer them automatically to the alcohol outreach team. Second, if they have issues with alcohol excess, they may have to be put on a medication to avoid a condition called delirium. So this will alert them. 3, if there are drugs that interact with alcohol, all of a sudden you can alert those drugs. So you can see what is a very basic thing now, very, very informative in terms of decision support, but also for research purpose. The second element is this. As you can see, as the patient deteriorates, the oxygen goes down, so you have to start on dexamethasone. When they have what we call acute kidney injury, you need to stop certain medication. When their blood glucose is not controlled for COVID, there are specific ways of controlling them. And all this, you cannot expect a junior doctor to know. And they are all in different sets of guidelines. So this is where decision support, a computer executable guideline, comes into play. And we are very fortunate to have Matt, who's now joined University of Birmingham from Oxford, who is developing this open source platform for creating computer executable guideline using this particular logic created by late Professor John Fox. Unfortunately, he died last year. So Matt and myself are hoping to take forward his legacy and make it available through the openclinical.net platform. So this is another part we do on top of Dexter. So in this sort of circumstance, if you click computer executable guideline, then all of a sudden you will find when the saturation drops, automatically the system will tell you to start dexamethasone. When you have acute kidney injury, the system will automatically tell you to stop SGLT2 and metformin, and so on. Okay. The third element is, of course, Dexter. If you have a question, do people with diabetes coming in with COVID have worse outcomes than people without diabetes but coming in with COVID? Can you answer this question in quick time? So in our hospital, there were 518 patients with COVID and diabetes, 1,410 with COVID, but no diabetes. And you can see their ages are very different. And what I haven't shown is there are another 20 parameters, their blood laboratory measurements, they're not similar. So we do what we call a simple propensity score matched study now. Both are very similar age, and you get some results. So you find that they are twice likely to receive dexamethasone treatment, which is an indication that they are probably having severe disease. But interestingly, in wave 2, the mortality was not any different. And that is simply because they have learned how to manage diabetes better during wave 2, whereas in wave 1, we did observe excess mortality. So they were still severe patients, but they were managed better, and therefore they had less death. Okay. And all that took 3 minutes, okay, to get that results. So that's what we call informatics consult. At bedside, can the clinician use a tool like Dexter to answer a question that will help them with their clinical practice? Taking that idea forward came Optimum. So what is Optimal? It's a range of people here and in Scotland who are using good quality data to answer important clinical questions using clever AI methods led by Christopher Yao, and also supported by our colleagues, Professor Peter Tino and others, to using Dexter to answer these questions. So what are we trying to do? Because of time, I'm going to be very short. If a person has multiple health condition and the GP wants to know what is the next likely disease and what is the best potential treatment for diabetes, given the person has coexisting health condition, how do we find that answer? So we will use data, AI methods, and Dexter to answer this question so that we know the person who has diabetes and these 3 health conditions already, what are their risk of major diseases, so cardiovascular risk disease, 80% in the next 5 years, and so on. But also give an indication by prescribing which drug, what effect it will have on the disease it was prescribed for, the disease that are coexisting at present, and diseases that are predicted to take place in the next few years. Okay, this is just a mock-up, so this is not the way to present. There is research, qualitative research on how best to present as well. It's about presenting in both focused on clinicians as well as a way of presenting it to patients. So we will be discussing these things in the future. I'm not going to talk about opera because we are running out of time, but let me say a few words what we plan to do next. So we really like to see this being used by many, and we are going to work with our local NHS organizations to see if we can implement so that they can make use of it. So for research and even quality improvement and or even informatics consult. How we do it, Dexter will be there in each of the hospital. A user interface can be even accessed externally. And a person who wants to do research in, say, organization B can put that request that will go for approval. And once approved, the data will be extracted as far as all 3 organizations agree. And then the data, depending on how they agree and what level they agree, either they might provide only aggregated data or they might provide a minimum data set that will go into the TRE workspace of the local hospital where it can be analyzed for future, next 5 years. And one of the key things is we cannot do this on our own, and we need a range of methodologies and people coming together. And what we are hoping with people like, well-able people like George Guterres in Birmingham and others, we are going to, under his leadership, we are going to create a center to bring this all together so we can address all these clinical themes and public health themes and potentially care related themes, as in social care, to create a learning health system that is fit for all. And we'll do this through 3 things. We'll create a Center for Health Data Science, primary focus NHS and global. We are exploiting the technology as a spin-out with a focus on industry, but also for universities at cost. And you will find that essentially it does 3 research fellows job for you. And then, of course, we have a global reach, and working with low middle income countries, we are establishing a center, for example, in Sri Lanka, where I come from, to also enable them where they have been affected severely due to various reasons throughout the last 30 years.